Good morning, everyone. Today, the topic of our lecture is bone loss and pattern of bone loss. The contents which we are going to discuss about this topic is the introduction, mechanism of bone formation or bone resorption, then bone destruction caused by extension of gingival inflammation, then bone destruction caused by trauma from occlusion, bone destruction caused by orthodontic type trauma, then bone destruction caused by systemic disorders, factors determining bone morphology in periodontal disease, bone destruction pattern in periodontal diseases, diagnosis, and finally the conclusion. So coming to the introduction, the height and density of alveolar bone are normally maintained by an equilibrium regulated by local and systemic influences between bone formation and bone resorption. So the height and density of alveolar bone can be maintained only when there is in systemic influence there is between which is regulated between the resorption and the bone formation. Both the process are taking simultaneously. They are taking place simultaneously and equally. If the bone resorption only takes place, then there will be destruction of the bone and there will be loss of bone. And if the bone formation takes place, then what happens? There is more amount of deposition of the bone, and that may lead to exostosis and such kind of. So in this picture, you can see that there is osteoclast formation, then there is active osteoclast formation, then mononuclear cells you can see that may lead to reversal phenomenon, then pre-osteoblast that lead to more bone formation, that is osteoblast, and then the mineralization takes place, that is osteocytes which are deposited on the surface. When the resorption exceeds formation, both bone height and bone density may be reduced. Okay, when the resorption is exceeded, then the formation, then the bone density will be reduced. How the mechanism of bone resorption takes place? There is a theory or method in which bone resorption, according to which bone salts can be removed by humoral mechanism and returned to the tissue fluids, leaving behind a decalcified bone matrix formation. Here you can see how the characterized by the presence of multilocated osteoclast in the regular concavities of the bone margin. Here you can see in the picture that there is osteoclast formation, carbonic anhydrase are present, which lead to hydrogen chlorine intake. When chlorine bicarbonate exchanges are present, chlorine and bicarbonate exchanger, the process is taking place, osteoclast formation, and then the bone mineralization takes place. Then what happens? There is attachment of osteoclast to the mineralized surface of the bone, creation of sealed acidic microenvironment through action of proton pump, which demineralizes bone and expose the organic matrix. There is degradation of the exposed matrix by the action of release of enzymes such as acid phosphatase and the cathepsin B, which are released at the margins. Then endocytosis at the ruffled borders of the organic degradation products. Then translocation of degradation product in transport vesicles and extracellular release along the membrane opposite the ruffled border. The coupling mechanism which is present when there is decreased blood calcium level, when there is calcium level is decreased in the blood, then there is parathormone hormone, there is release of parathormone which leads to formation of the osteoblast which lead to formation of the cells, then more formation of the bone which releases interleukin 1 and interleukin 6 that leads to migration of the monocytes on the bone area, and the bone resorption takes place when calcium ions are released, normal blood calcium levels, which inhibits parathyroid hormone levels. The factors involved in bone destruction in periodontal disease are bacterial and host mediated. Like pathogen associated molecular patterns are capable of eliciting an immune response. Once the immune and inflammatory process are initiated, various inflammatory molecules, including proteases, cytokines, prostaglandins, are released from leukocytes and fibroblasts. Then the bacterial plaque products and tissue mediators like cytokines like interleukin 1, interleukin 6, and tumor necrosis factor alpha, and PG to modulate osteoclastogenesis by enhancing osteoclast differentiation activation. This is how you can see in the bigger picture that periopathogenic bacteria which are present, they release lipopolysaccharides, which releases cytokines like interleukin 1, tumor necrosis factor alpha, interleukin 6. The osteoclast gets activates, that rank and rank 2 formation is present. Then precursor cells which differentiate and activation takes place, and active osteoclast which activates osteoclast, and there is bone resorption. Here the local factors which are present, local factors like interleukin 1, then prostaglandin E2, then tumor necrosis factor alpha, which inhibits the interleukin 1, inhibits osteoblast differentiation, then it inhibits factor production, tumor tissue growth factor, then bone morphogenic proteins, it inhibits matrix production, then it increases osteoblast differentiation, and then pre-osteoclast formation which takes place that may lead to bone resorption and bone formation. Now, how the bone destruction can be caused due to gingival inflammation. So, the most common cause of bone destruction in the periodontal disease is the extension of inflammation from marginal gingiva into the supporting periodontal tissues. The inflammatory invasion of the bone surface and the initial bone loss that follows mark the transition from gingivitis to periodontitis. The extension of inflammation to the supporting structure of tooth may be modified by pathogenic potential of plaque, resistance of the host, immunologic activity, then degree of fibrosis of gingiva, width of the attached gingiva. These all are osteogenesis which takes place. Pathways of inflammation. Like gingival inflammation extend along collagen fiber bundles and follows the course of blood vessels through the loosely arranged tissues around them into the alveolar bone. Then interproximally, inflammation spread to loose connective tissue around blood vessels through fibers and then into the bone through vessels, channels that perforate the crest of the interdental septum at the center of the crest, towards the side of the crest, or at the angle of the septum. Less frequently, inflammation spreads from gingiva directly into the periodontal ligament. You can see from the gingiva, it is going into the gingiva and into the bone. Facial and lingual inflammation from the gingiva spreads along outer periosteal surface of the bone and penetrate into the marrow space through vessel channels. Along its course from the gingiva to the bone, the inflammation destroys gingival and transeptal fibers. However, there is continuous tendency to recreate transeptal fibers across the crest farther along the root as the bone destruction progresses. As a result, transeptal fibers are present even in cases of extreme periodontal bone loss. Possible changes in the pathways of gingival inflammation caused by trauma from occlusion. There are two concepts like Glickman concept and the Vero concept. Now coming to histopathology, how the inflammation reaches the bone from the gingiva. Inflammation spreads into the marrow spaces that replaces the marrow with leukocytic and fluid exudate, new blood vessels and proliferating fibroblasts. Multinuclear osteoclasts and mononuclear phagocytes that increase in number, then bone surface appear lined with Horseshoe's lacunae. In marrow spaces, resorption proceeds from within the causing the thinning of surrounding bone in trabeculae. Enlargement of spaces followed by destruction of the bone and reduction and bone height. So these are how the marrow totally or partially replaced by the fibrous type of the marrow. And Grant and co suggested that locally produced bone resorption factors may need to be present in the proximity of the bone surface. Their Page and Schroeder postulated a range of effectiveness of about 1.5 to 2.5 millimeter within which bacterial plaque can induce bone loss. Then how the rate of bone loss takes place. There are some famous Sri Lanka tea workers, Low et al., who has done the study in which on the facial surface there is 0.2 mm per year the loss of bone takes place, and in proximal surfaces 0.3 millimeter per year the loss takes place. Low and poor workers identified three subgroups of the patient. 8% of the person rapid progression of the periodontal disease, then 81% of the individuals moderately progressive periodontal disease. How the periods of destruction takes place. Destruction periods result in loss of collagen and alveolar bone with deepening of the periodontal pockets. These are the different types of bone loss, how it takes place. Then the bone destruction caused by trauma from occlusion. How from, as you all know, from trauma from occlusion, there are different causes which lead to problem like pathological migration, then dentoalveolar ridge loss while doing the extraction. These are things that may lead to trauma from occlusion. In the absence of inflammation, what happens? The trauma from occlusion do not result in pocket formation or in loss of connective tissue. Trauma from occlusion cannot induce periodontal tissue breakdown. It results in resorption of the alveolar bone, leading to an increased tooth mobility, which can be of transient or permanent character. Changes varies from compression and tension of periodontal ligament osteoclasis of alveolar bone to necrosis of the periodontal ligament and bone and the resorption of bone and tooth structure. These changes are reversible if the offending forces are removed. So persistent TFO result in funnel-shaped widening of the crestal portion of the periodontal ligament and angular-shaped bone crest. This should be regarded as a physiological adaptation of the periodontal ligament and surrounding alveolar bone to the traumatizing forces, that is to altered function demands. In presence of inflammation in teeth with progressive plaque-associated periodontal disease, TFO enhance the rate of progression of the disease, that is act as a cofactor in the destruction process and result in bizarre bone patterns. Now the bone destruction caused by the orthodontic type of trauma. When a tooth is exposed to unilateral forces of magnitude, frequency or duration that its periodontal tissue distribute while maintaining the stability of the tooth, certain well-defined reactions develop in the periodontal ligament, eventually resulting in an adaptation of the periodontal structure to the altered functional demands. If the crown of the tooth is affected by such horizontally directed forces, the tooth tends to tilt in the direction of the force. This tilting force results in development of pressure and tension zones within the marginal and apical parts of the periodontium. So here, as you can see, the tissue reaction which develops in pressure zone are characterized by increased vascularization, increased vascular permeability, vascular thrombosis, and disorganization of cells and collagen fiber bundles. If the magnitude of forces is within certain limits allowing the maintenance of the vitality of the periodontal ligament cells, bone resorbing osteoclasts soon appear on the bone surface of the alveolus in the pressure zone. The process of bone resorption is initiated. This phenomenon is called direct bone resorption. If the force is of higher magnitude, the result may be necrosis of the periodontal ligament tissue in the pressure zone, that is decomposition of these cells, vessels, matrix, and fibers. So this is how the indirect bone resorption is initiated in orthodontic type of inflammation or the bone formation. Bone destruction caused by systemic disorder. This is a very important, one of the important thing, how the systemic diseases may lead to destruction of the bone. Periodontitis and osteoporosis share a number of risk factors, that is aging, smoking, diseases, medications that interfere with the healing. So periodontal bone loss may also occur in generalized skeletal disturbances such as hyperparathyroidism, leukemia, Langerhans cells, and histiocytosis. Periodontal bone loss that may lead to factors determining bone morphology in periodontal diseases. There are certain factors which bone morphology which may formation on which bone formation and bone resorption is dependent, like thickness, width, and crestal angulation of the interdental septum, and thickness of facial and lingual alveolar plates, presence of fenestrations and dehiscence, alignment of the teeth, root and trunk anatomy, root position within the alveolar process, proximity with another tooth surface, like exostosis, outgrowths of the bone of varied size and the shape. Then palatal exostosis, found in 40% of the human skulls, occur as small nodules, large nodules, sharp ridges, spike-like projections, or combination of these. So that also affect the formation of the bone and loss of the bone. In trauma from occlusion, it causes thickening of the cervical margins of the alveolar bone with changes in the morphology of the bone. Example, angular defects and buttressing bone. Buttressing bone formation, attempt to buttress bony trabeculae is weakened by the resorption. Central buttressing bone formation within the jaw. Then the later may cause bulging of the bone contour termed as lipping. Bulging of the bone contour that is termed as lipping. Then food impaction. Food impaction, it also plays a very major role in bone formation and bone loss. Interdental bone defect often occur where proximal contact is abnormal or absent. Pressure and irritation from food infection contribute to inverted bone architecture, negative bone architecture. Poor proximal relationship may result from shift in tooth position because of extensive bone destruction. Then aggressive periodontitis. Vertical or angular pattern of alveolar bone destruction in first molars. Then the cause of localized bone destruction in this type of periodontal diseases, as it occurs in aggressive periodontitis, it occurs in the younger patients. So there is more amount of loss of bone in comparison to the time. In less time, there is more amount of bone destruction which can be seen here. Bone destruction patterns in periodontal disease. You can see here the ideal osseous structures. Positive osseous structures, scalopic and elbow is parallel to adjacent cementonemal margins, then festooned and buccolingual contour can be seen. Then different types of defects. A deviation from normal form or contour of soft or hard tissues, or fault, imperfect shortcomings. Different type of defects like one wall defect, two wall defect, and three wall defect. So according to that, there are ledges or things. And proximal, according to Goldman and Cohen, according to morphology of the bone defect, there are three osseous walls: proximal, buccal, and lingual walls. Buccal, mesial, and distal walls, and lingual, mesial, and distal walls. Two osseous walls you can see here: the buccal wall and the lingual wall. Buccal and the proximal wall is missing. Lingual or the proximal wall is missing. These two walls you can see. And one osseous wall in which proximal wall may be missing, or buccal wall may be missing, or the lingual wall may be missing. Or there can be combination three walls plus two walls, and three walls plus two walls plus one wall, three walls plus one wall, and two wall plus. Here you can see the uh, mesial wall, buccal wall, and the proximal wall, and this is the buccal wall, this is the mesial wall, the distal wall. Then also there are osseous interdental craters like the hemiseptal defect, intrabony defects, bulbous bone contours, inconsistent margins and ledges, and reverse architecture. Ricard, he expanded this classification, included furcation involvement, anatomic aberration of the alveolar process, that is thick marginal edges, then exostosis and toroid dehiscence and fenestration. Horizontal bones, it is the most common pattern. Bone is reduced in height, but bone margins remains roughly perpendicular to the tooth surface. Then interdental septa, facial and lingual plates are affected, but not necessarily to equal degree around the same tooth. Vertical or angular defects. Vertical or angular defects, it occurs in an oblique direction, leaving a hollowed out tuft in the bone along the side of the tooth. Base of the defect is located apical to the surrounding bone. Most of the instances accompanied by intrabony defect. Then it is classified as 1, 2, or 3 wall or combined defect. Classified as 1, 2, or 3 wall or combined defects. Now you can see here the defect anatomy. 1, 2, 3, and wall defect, wide and narrow defect. The wide defect, it can be shallow also and deep. Then narrow, it can be shallow and deep. And accordingly, then hemiseptal defects. Hemiseptal defects are 1 or 2 wall defects that often are found around measly tipped teeth. The hemiseptal defect is mostly seen in the 1 or 2 wall defect that often are found around measly tipped teeth. Then circumferential defect, which can be seen here circumferentially around the tooth. Osseous craters, concavities in the crest of interdental bone. Osseous craters are the concavities in the crest of interdental bones. This 1/3 of all the defects are osseous craters, 2/3 of all mandibular defects are osseous craters. It is twice common in posterior segments. Height of facial and lingual crest of crater are identical in 85% of the cases, with remaining 15% being nearly equally divided between higher facial crest and higher lingual crest. Here you can see the craters in the interdental area. Following reasons for high frequency interdental craters are interdental area collects flat and interdent difficult to clean. Normal flat or even concave facial lingual shape of the interdental septum, and vascular patterns from the gingiva to the center of the crest may provide the pathway for inflammation. Then you can see the bulbous bone contours. Bony enlargement caused by exostosis, adaptation to functional buttressing bone formations is present, then more frequently seen in the maxilla. Bulbous bone formation is most frequently seen in the maxilla. Then ledges, plateau-like bone margins caused by resorption of thickened bone plates. Reverse architecture produced by loss of interdental bone, including facial and lingual plates without loss of radicular bone, more common in the maxilla. It is more common in the maxilla. Then ledges, plateau-like bone form margins caused by resorption of thickened bony plates. Reverse architecture, fenestration and dehiscence. Fenestration, isolated areas in which the root is denuded of the bone and the root surface is covered by bone and the root surface is covered only by the periosteum and overlying gingiva. Dehiscence, when the denuded areas extend to the marginal bone. When the denuded area extend to the marginal bone, it is dehiscence. And isolated areas in which the root is denuded of bone is fenestration. Bifurcation involvement. Invasion of bifurcation and trifurcation of multi-rooted teeth by periodontal disease is known as furcation. Grade 1 involvement, incipient or early lesion, pocket formation is suprabony, bone loss is minimal, radiographic change is not usually visible. Grade 1 involvement in incipient or early lesion, pocket formation is suprabony, bone loss is minimal, radiographic change is not. Grade 2 involvement, bone destroyed on one or more aspect, cul-de-sac lesion, depth of the horizontal component, vertical bone loss may be present, and radiograph may or may not reveal the grade 2 furcation. In grade 2 involvement, bone is destroyed on one or more aspect, cul-de-sac lesion, depth of the horizontal component, vertical bone loss may be present. Radiograph may or may not reveal the grade 2 furcation. Grade 3 involvement, complete loss of interradicular bone, through and through tunnel, crater-like lesion, apical or vertical components, radiograph radiolucent areas. Grade 3, there is complete loss of interradicular bone, through and through tunnel, crater-like lesion, apical or vertical component, and radiographic lucent area. In grade 4, interradicular bone completely lost, periodontal probe passes from one aspect of the tooth to another, radiographic features same as grade 3. M et al. Degree 1, horizontal loss of periodontal support not exceeding 1/3 the width of the tooth. Degree 2, horizontal loss exceeding 1/3 the width of the tooth. Degree 3, horizontal through and through destruction. Then Ramford and Asher also given. Class 1, bending involvement, tissue destruction not extending more than 2 mm. Then class 2, cul-de-sac involvement, tissue destruction extend to 2 mm through and through, tissue destruction extend throughout the entire length of furcation. And Linde and Nyman, horizontal loss is equal to 1/3 of the width of the root. Then horizontal loss less than 1/3 of the teeth width of the root. Then degree through and through loss. Tanu and Fletcher. Subclass A, 0 to 3 millimeter vertical destruction of bone loss furcation. Then subclass B, 4 to 6 millimeter vertical destruction of bone from furcation root. Subclass C, 7 millimeter bone. Here you can see the 0 to 3 millimeter vertical destruction. Here you can see the 4 to 6 millimeter destruction. Here you can see the 7 millimeter destruction. ESCO and Capin subclass A, vertical destruction up to 1/3 of the total interradicular height. Then subclass B, vertical destruction up to 2/3 of the total interradicular height. Subclass C, interradicular osseous destruction into or beyond the apical third. Bone loss around implants. Similar types of bone loss also occurs around the implants. Classic rough type defect is typically associated with peri-implantitis. Coming to diagnosis. How you should diagnose the osseous defects. So first you should do the digital examination, then probing, transgingival probing, radiographs and surgical exposure. Advanced diagnostic aids, digital radiography is present, subtraction radiography, then computer assisted densitometric image analysis system, computerized tomography, photodensitometric image analysis technique. Diagnostic markers of periodontal bone resorption. By cytokines, the host-derived enzymes are alkaline phosphatase, extracellular matrix component, osteonectin. Interleukin 1, 6, and chemonecrosis factor alpha, collagenase, and related MMP, osteocalcin, prostaglandin E2, stromatolacin, and elastase, cross-linked carboxy terminal pilopeptide of type 1 collagen. This is how in transgingival probing, with the help of Navis probe, you put the probe into the furcation area, and according to that you determine whether you can which type of defect is that. Then radiographs also, surgical exposure which is present, bone loss around the implant. Similar type of bone loss also occurs around the implants. A classic trough type defect is typically associated with peri-implantitis, so that has to be. Then one of the important thing which we should discuss is about the histopathology, how the inflammation reaches to the bone from the gingiva. So first the inflammation spread into the marrow spaces. First the inflammation takes place and it will space into the marrow spaces. Then what happens? There is replacement of the marrow with leukocytic. In leukocytic infiltration, you must have seen that the macrophages are present and it infiltrate, exudate, new blood vessels and proliferating fibroblasts are present. Then multinuclear osteoclast and mononuclear phagocytes increase in number, and bone surface appear lined with house-shaped lacunae. In marrow spaces, resorption proceeds from within, causing the thinning of surrounding bony trabeculae. Then there is enlargement of the spaces followed by destruction of the bone and reduction in the bone height. Then fatty marrow totally or partially replaced by fibrous type of the marrow. The radius of the action is 1.5 to 2.5. Beyond 2.5 millimeter, what happens? There is no effect. Interproximal angular defects are only in spaces that are wider than 2.5 millimeter. Carenza et al. Has suggested that large defect exceeding distance of 2.5 millimeter from tooth surface may be caused by presence of bacteria in the tissues. So that should be kept in mind. Then rate of bone loss, 0.2 millimeter per year facial surfaces, 0.3 millimeter per year proximal surfaces. 8% of the person rapid progression of the periodontal disease, that is 0.1 to 1 millimeter loss of attachment per year. 81% of the individuals moderately progressive periodontal disease, 0.05 to 0.5 millimeter loss of attachment per year. The remaining 11% of the persons minimal progression of the disease, 0.05 to 0.09 millimeter loss of attachment per year. The destruction, how it takes place. Then burst of Burst of destructive activity associated with subgingival ulceration and an acute inflammatory reaction, resulting in rapid loss of alveolar bone. Burst of destructive activity, according to Seymour, coincide with the conversion of predominantly T lymphocyte lesion to one with a predominantly B lymphocyte plasma cell infiltrate. Periods of exacerbation are associated with an increase of the loose, unattached, motile, gram-negative anaerobic pocket flora, and periods of remission coincide with the formation of dense, unattached, non-motile gram-positive flora with a tendency to mineralize. Tissue invasion by one or more bacteria is followed by an advanced local host defense that controls the attack. Bone destruction caused by trauma from occlusion. Trauma from occlusion is the most important factor which should be kept in mind and which should be ruled out on time so that it affects the outcome of the treatment which you're doing after the bone loss and patterns of the bone loss. Changes varies from compression and tension of periodontal ligament and osteoclasis of alveolar bone to necrosis of the periodontal ligament and bone and the resorption of the bone and root structure which takes place. So the bacteria, when it invades into the pocket, then it releases endotoxins through fimbriae, through endotoxins which reduces different type of cytokines like interleukin 1, interleukin 6, interleukin alpha, beta, which leads to the suppression of the immunity. Parathyroid hormone is decreased. There is release of calcium ions from the blood, and so that further lead to bone resorption. The coupling mechanism which takes place. Then the presence of inflammation in teeth with progressive plaque associated periodontal disease, trauma from occlusion, and hence the rate of progression of the disease, that is act of cofactor in the destruction process of the resulting bizarre appearance. Then also the diabetes systemic factors which we have discovered. The diabetes on the periodontium is also one of the important factors which we should rule out. The glucose content of the gingival fluid is increased in diabetes. This alters the environment of the microflora. So the subgingival flora, what happens, there is presence of the porphyrin gingivalis, pivotal intermedia, and periodontal lesions. With type 2 diabetes is more. So subgingival flora composed of mainly capnocytophagia, anaerobic fibrous. There's what happens is there is altered neutrophil function resulting in impaired chemotaxis, defective phagocytosis, or impaired adherence that lead to altered collagen metabolism and decreased collagen synthesis. Also, in case of generalized aggressive periodontitis, encompasses the disease previously classified. Then also you can see that necrotizing ulcerative gingivitis is less commonly seen in HIV patients if present resembles NL. Although other microorganisms which are present may lead to the you can go for the treatment like different type of procedures which are present for restoring the bone. Most common area which is affected are the interdental area. What happens? The interdental area collects the plaque and it is difficult to clean. So the normal flat or even slightly concave facial lingual shape of the interdental septum is in lower molar may favor crater formation. Vascular patterns from the gingiva to the center of the crest may provide a pathway of inflammation that may further invade deeply. Then following have been reported that different oral epithelium which is present that renews every 24 hours of the periodicity. These are the all important topics which I have discussed. Also, you can read from the calendar chapters, see reconstructive and surgery, in which everything else is given. If you have any problem, you can ask the queries. All things has to be discussed, which I have discussed. One more important thing is about the different shapes or the tooth morphology which is present that may lead to formation of the formation and destruction of the bone, like the buttressing bone formation. So peripheral buttressing bone formation on the external surface. It takes place on the external surface, not on the internal surface. So that has to be remembered. Then the latter may cause bulging of the bone contour term lipping. The bone contouring which happens, the important term is the name which is given is lipping. And then food impaction. It is the most commonly seen in the patient which is coming to the clinics that interdental bone defect often occurs because of the food impaction. There is the patient cannot clean that area, so there again there is food infection. Aggressive periodontitis also, there is swelling of the gums. You can see first you have to go for gingivectomy, and the antibiotics you have to put the patient on antibiotics, and then further you can go for the procedure. Then the defects which are present, this is also very important, like the three osseous walls, and the three osseous walls which can, according to morphology of the bone defect, the name is given on the basis of the number of the walls present, not the number of the walls lost. Like three walls, three osseous wall defect means the only one wall is missing and the three walls are present, like the proximal, buccal and lingual walls, buccal, mesial, and the distal walls, and the lingual, mesial, and the distal walls. Then the two osseous walls, like the buccal and the lingual walls, in which two walls are present and the one wall is missing. And the buccal and the proximal walls, lingual and the proximal walls, and in one osseous wall defect, the proximal wall, only one wall is present and the rest two are missing, like the proximal wall, buccal wall, and the lingual wall. So this is the most important thing which should be kept in mind. The rest is discovered. So we come to the end of the topic. Thank you so much.